Sounds good. All right. Good morning. This is a public hearing before the Office of Medicaid Policy and Planning on the 27th day of October, 2025. Supposed to be at 10 a.m., slightly late start at 10:12 a.m. at the Indiana Government Center South, 402 West Washington Street, Conference Center Room 3, Indianapolis, Indiana, and is also being live streamed with a remote attendance option via Zoom. This proposed rule will amend rules at 405 IAC 5 concerning the professional dispensing fee. Notice of time and place of this hearing was given as provided by law. By publishing on September 17th, 2025 on the Indiana Register. My name is Amanda DeRoss, and I have been appointed hearing officer by the Office of Medicaid Policy and Planning. As the hearing officer, I will not answer questions or provide comments on the proposed rule during this public hearing. The sign-in sheet should be completed by all individuals desiring to be shown as appearing of record and shall be completed by those who desire to be heard during this hearing. If you have not already signed the sheet, please do so at this time. You will also find a copy of the proposed rule, which you are welcome to take a copy of. Additionally, the proposed rule is posted on the FSSA's website at www.in.gov/FSSA under Rulemaking Notices and Updates. If you are joining via Zoom, please use the chat feature to write your name and affiliation in the chat box. Oral statements will be heard today, and written statements may be handed to me, emailed to me at fssarulecomments@fssa.in.gov, or mailed to me at FSSA Attention Amanda DeRoss, 402 West Washington Street, room W451, Indianapolis, Indiana 46204. Correspondent should be identified with comment regarding LSA document number 25-436. Comments will be accepted until the end of today, October 27th, 2025. Each person who speaks for the record is requested to clearly identify yourself by giving your name, spelling it, and identifying who you represent. For those on Zoom, your microphones are currently muted. If you would like to make a comment, please use the raised hand or chat feature to let us know, and we will unmute you. Is there anyone who cares to be heard? And nobody on Zoom. Whoever wants to go first, you're up. I think we'll have you sit here potentially.
All right. Hello, my name is Ryan Ades, first name R-Y-A-N, last name A-D-E-S. I'm representing myself and the Indiana Pharmacy Association. I'm the current president of the Indiana Pharmacy Association, a practicing pharmacist, and a Hoosier taxpayer. I urge you to reject the proposed rule change to lower the pharmacy dispensing fee from the current rate of $10.48 to $9.63. Not only would this change have devastating consequences for community pharmacies across the state and Medicaid patients they serve, but this action is not in alignment with the statutory requirements for such a change. There are far more effective means for reducing the cost of Medicaid to the state of Indiana, which we have seen save hundreds of millions of dollars in other states. Consider first that this action is not in compliance with the law, specifically Indiana Code 12-1531.14, which notes if an adjustment in dispensing fees is made following a survey conducted under Section 1 of this chapter, the Secretary shall commence the rulemaking process under Indiana Code 422.2 to make the adjustment not later than November 1st of the year in which the survey was conducted. The survey utilized in recommending this change was published in June of 2024, meaning that this proposed adjustment to pharmacy dispensing fees violates Indiana Code 12-1531.14. The potential savings the state would discover if they lowered the pharmacy dispensing fee as proposed is estimated at $1.15 million. This is nothing compared to the savings seen in other states when reining in the true driver of excess Medicaid spending, pharmacy benefit managers. The House Enrolled Act 1445 audit report prepared for the Office of the Attorney General and distributed in August of 2024 outlined the impact of PBMs involved in Indiana Medicaid. The study showed spread pricing practices instituted by PBMs under Indiana's Medicaid managed care organizations costing taxpayers $322.4 million. Other states, most notably Ohio and Kentucky, have recently changed PBM practices associated with state plans and saved hundreds of millions of dollars for their constituents. Kentucky changed to a single preferred drug list and a single PBM for all Medicaid patients and realized a cost avoidance of $282.7 million over 2 years when compared to their previous Medicaid PBM structure. Ohio noted $224 million in spread pricing over 12 months in 2018 and increased pharmacy closures associated with lower reimbursements. They updated Medicaid contracting to utilize transparent pricing in a single PBM and saw $312.4 million in savings over a 2-year period. FSSA and OMPP should focus on fixing the broken pharmacy benefit management system in Indiana for real savings, not further reducing the reimbursement provided to the biggest victims of these practices, community pharmacies. The state of Virginia recently published a damning report highlighting that what can happen to drug costs when PBMs are not appropriately regulated and held accountable, noting that utilization of the National Average Drug Acquisition Cost, or NADAC, plus a professional dispensing fee would have saved the state $880 million in 2023 alone. Virginia is also moving to a single PBM to serve the Medicaid program more effectively, to increase transparency, and to rein in drug spending. There are many more examples of PBM practices as the true cause of increases in Medicaid expenditures, but I won't belabor the point here. The important thing to note today is that a decrease to the current pharmacy dispensing fee does not satisfactorily address the issue, is not a legally viable option, and will only hurt the ability of community pharmacies in Indiana to serve patients covered by Indiana Medicaid. I urge you not to pursue a decrease in the pharmacy dispensing fee from the current rate of $10.48. Thank you.
Good morning. My name is Matthew Williams, Matthew Williams, and I'm a certified pharmacy technician at Nations Medicines, an independent pharmacy in Evansville, Indiana. Thank you for the opportunity to speak about the proposed 8% reduction in Medicaid dispensing fees. I'd like to focus on one simple point. The data from the 2024 cost of dispensing survey does not align with the national or regional trends in pharmacy operating costs. Let's start with what the report actually says. Out of 1,442 eligible responses, 960 were usable in the survey. Of those, 890 were from chain pharmacies and only 70 were from independents. That means there was a 91.9% usable rate from chains versus just 14.8% for independents, a statistically significant imbalance that was not corrected for in the weighting process. Because chains generally have lower per prescription costs due to scale, this imbalance inevitably pushes down the reported average. Now, compare that to our neighbor, Ohio. Ohio's 2024 cost of dispensing survey, conducted by the same vendor, Myers and Stauffer, surveyed 2,579 pharmacies and received 2,262 usable responses. Of those, 1,723 were chain and 539 were independent. This gave it 87.7% usable response rate. Ohio law requires participation, ensuring a representative sample across both chains and independents. Their Medicaid weighted mean cost of dispensing was $11.60 per prescription for all pharmacies and $10.61 for non-specialty pharmacies, substantially higher than Indiana's $9.63 proposed, despite the same survey methodology. National data also confirms that dispensing fees costs are stable or rising, not falling. The ABT Associates NACDS survey covering 2018 data found on average that the average cost was more than $12 per prescription nationwide. In addition, just recently, the 2025 NCPA Digest showed that the average cost of dispensing was $15, which was up from $13 in 2023. So when Indiana's data shows a sharp drop in the cost, while every comparable state shows flat or increasing costs, we have to look at the methodology, not the actual reality. The skewed participation, exclusion of certain operating expenses, and use of a generic inflation index all bias the result downward. Reducing the dispensing fee on that basis would threaten pharmacy participation in Medicaid, particularly among independents like mine, serving rural and medically underserved communities. I respectfully urge FSSA to delay implementation of this fee reduction until the underlying data is released, the results are reweighted to reflect true participation, and an independent review verifies the findings. Thank you for your time, for your commitment to preserving pharmacy access for Hoosiers who depend on Medicaid. That's all. Yes.
Hello, my name is Harry Webb. It's spelled Harrywebb. I own 3 independent pharmacies in north central Indiana. The stores are in Rochester, Akron, and North Manchester. In 2024, we filled over 161,000 prescriptions. By volume, only 8% of those were Medicaid and Medicaid managed care, which is lower than the national statistic. While it may seem modest, the most recent dispensing fee cuts combined with rock bottom managed care reimbursement has forced me to reconsider whether I can continue to serve this vulnerable population. Quite simply, the report is flawed and has biased data. The Meyer and Stauffer report is fundamentally flawed. Only 15% of independent pharmacies respond compared to 92% of chains, a statistically significant bias. My 3 stores were part of those that did not respond. This poor response rate was driven by a compressed survey timeline, which made it nearly impossible for small pharmacies to compile accurate financial data. Our year-end accounting depends on several delayed inputs, such as rebates. We don't find out about those until late January or February. 1099s from vendors, 401k contributions, and profit-sharing calculations aren't finalized until late March. The survey deadline of February 2nd did not align with these realities, further limiting the accuracy and representativeness of the data collected. The report miscalculated overhead significantly. Unlike chains, independents typically have minimal front-end sales and no liquor departments. Typically, an independent pharmacy, 97 to 99% of their sales is pharmacy and pharmacy prescriptions. Yet we operate in large, older buildings where pharmacies occupy maybe 30% or 40% of the total square footage. Despite this, key expenses like rent, repairs, maintenance, janitorial services, trash removal, utilities, and depreciation are calculated based on the square footage of the pharmacy department rather than the pharmacy sales volume. Expenses should be based on the licensed area. Most independent pharmacies, the licensed area is the entire store. And without pharmacy sales, there would not be a business at that location. Not as a percentage footprint of the actual pharmacy department. This approach grossly misrepresents the true cost of dispensing. It also excludes key labor costs, like the staff who handle claim reconciliation, payroll, and compliance, and ignores the absence of automation in independent settings. We serve patients, not algorithms. If Indiana Medicaid's goal is to eliminate independent pharmacies, this flawed Myers and Stauffer report offers a clearer roadmap for doing so. On a national level, as just recently mentioned, according to the 2025 Lilly Digest, the actual average cost of dispensing in the United States, is calculated by the University of Mississippi, is $15 per prescription. Medicaid accounts for about 18% of prescriptions at independents. Gross profit margins last year were 18.2%, which is lowest in a decade and probably lowest ever. Nearly 2/3 of independents serve towns under 50,000, and there's only 127 independent pharmacies remaining in Indiana as of July. These numbers reflect a sector in crisis, and Myers and Stauffer report fails to capture this reality. The real problem is spread pricing and systemic waste. As mentioned, House Bill 1445 audit found Indiana overpaid PBMs by $224 million in Medicaid alone, largely due to spread pricing. PBMs reimburse pharmacies below cost while billing the state for far more. In managed care, we often get paid less than $1 per prescription, despite the report confirming a truer higher cost of dispensing. This is not just inefficiency, it's a deliberate extraction of public funds that undermine care. And it's a huge community impact. Recently in Rochester, the Walgreens store closed. We saw a surge of Medicaid patients desperate for care. We became their lifeline, not just for prescriptions, but for medical questions, crisis support, and urgent guidance. We have patients that literally call us on a daily basis asking for help on something. These are not services we get reimbursed for, but it's why we practice in this profession. This level of care has prevented countless emergency room visits. Chain models relying on AI and central fill cannot meet these needs. You can't even get through on a phone and calling some chain stores. The only option is to leave a message and hope for a callback. And if you can't get prescriptions filled on the same day, what's the point? If you rely on transportation to go to the doctor, then come to the pharmacy, then you have to have more expense to come back and get the prescription the following day. That's not the model that happens in independent pharmacy. Closures and unsustained cuts. Indiana has lost 26 pharmacies in just the last 8 months. I've added staff to meet the rising demand, but if cuts continue, I will be forced to trim staff or exit Medicaid altogether. Other independents in Indiana already have. A much better path is a single-payer pharmacy reimbursement. Indiana's fragmented system invites exploitation. A single-payer model administered directly by Medicaid would eliminate spread pricing, create uniform reimbursement across all Medicaid programs, it would preserve rural access, and it would streamline compliance and reduce audit risk. I urge Indiana Medicaid to reject rate cuts based on this flawed data. Establish reimbursement floor that reflects actual costs, transition to a single-payer pharmacy reimbursement model, and hold PBMs accountable for transparency and fairness. And in closing, if there is ever an example of the old idiom, penny wise and pound foolish, it's this proposed rate cut. Cutting the dispensing fee at a time when pharmacies are closing at an alarming rate is short-sighted. A true savings to the program you seek is in eliminating spread pricing and by working with your neighborhood pharmacies to expand services and compensate fairly. Independent pharmacies are more than a place to pick up prescriptions. We are the front door to healthcare in our communities. We provide point-of-care testing, home-based long-term care, vaccinations, chronic disease support, and a trusted relationship that no chain or algorithm can replicate. We are ready to collaborate with Medicaid to build a sustainable, patient-centered model, but we need fair reimbursement, transparency, and inclusion, not exclusion. Thank you for your consideration.
Is there anybody else who cares to be heard? All right, seeing and hearing no one else who cares to be heard at this time, I want to thank each of you for your attendance. The time is now 10:31 a.m. These proceedings pursuant to notice are hereby concluded.